Sethi. Vani Sethi is PhD in Public Health and Nutrition in the Nutrition Division, UNICEF, India, presently leading a girls and women's nutrition program, linking women's program, linking nutrition based in livelihood and empowerment and supporting the Ministry of Health in maternal malnutrition and anemia program. And she has 2 decades of work experience with government bodies and international organizations like the UN. Dr. Sethi excels in nutrition policy advocacy, program and policy, development research, implementation, institutional capacity building, monitoring and evaluation. At presently, she is doing a project. She's principal investigator of impact evaluation of preconception women's nutritional trial, Sabiman, running in the 5 blocks across Bihar, Odisha, and Chhattisgarh. Now I request Professor Sachdeva to carry out this session. And this is the last session of the day, so you can take a little more time if you wish. Otherwise, we have given time for all the panel members to 15 minutes time we have given. Thank you very much.
Thank you, Professor Syed Unisa, for inviting me to this. You told me that I am a busy person, but I think I am much less busy currently than all the esteemed speakers who are putting in there a lot of effort as far as the COVID is concerned. So as Professor Unisa has said that first, the time allocated to each speaker is 15 minutes. So we will have all the 4 presentations and then the discussant will summarize them at the end of that. And after that, we will have some time for questions and answers, for which I would request the participants to write their name and the question and the speaker to which it is directed, and they will attempt to answer and satisfy you for this. So it's now my proud privilege and pleasure to introduce the first speaker, Dr. Nilima Kshirsagar. I wonder if she recalls about 2 decades back, we had interacted when I was editor-in-chief of Indian Pediatrics, and she may not remember it at this time. She is currently the Emeritus Scientist, former National Chair of Clinical Pharmacology at the Indian Council of Medical Research, New Delhi. Her areas of expertise include clinical trials, pharmacovigilance, drug development, tropical diseases, drug resistance, and medical education. She is chairperson of several important committees such as WHO Committee on Product Development, Advisory Committee for Safety of Medicinal Plants, Drug Statistics, Methodology. She has received many awards, which would take some time to go, and prominent among them is the BC Roy National Award for Industrial Research. And now I would like to invite her to please speak on public health in COVID-19, success and failure. The floor is yours, Dr. Nilima.
Thank you very much, Dr. Sachdeva, for that kind introduction. I very much remember, of course, who can forget any interaction with you, Dr. Sachdeva? Not possible. It's a privilege to be here once again meeting you. And I thank Professor James and Unisa and her colleague for organizing this wonderful seminar. I've attended some of the plenary sessions yesterday, and it's very well organized and excellent seminar. I would like to share my presentation. Can I be given the option for sharing? But otherwise, I've also sent it to you. It will be good if I can share myself. Can you give me the, I've got it now. Okay, I will do that now. And can somebody tell me again? What do I have to press after I say share?
Madam, just click on a share, and screen 1 option is over there.
Screen 1, okay.
Okay, so that your desktop screen will be shared right now.
Yeah, I already have my desktop.
Yes,
so
madam. Yes, madam.
Slideshow from the beginning.
Yes, madam.
Are the slides visible?
Yes, madam. Contents.
Okay.
I am already at the content. Okay. Yes, ma'am. It is the first slide right
I'm
now.
on the first slide. I'm on the first slide. Is that correct? Can you
Yes,
see
ma'am.
that
Yes,
first
ma'am.
slide?
Yes,
Okay.
ma'am. Yes, ma'am.
Am I audible? Am I audible?
Yes, ma'am. Yes, ma'am.
Okay, good. Now, when I move to the next one, I hope just tell me if I can be seen. The side, not me, the slides can be seen. So my topic is public health in the era of pandemic, some of the successes and failures that we have faced. But since I'm one of the first speakers on this topic, I thought let me just quickly recapitulate what's public health, who are the stakeholders in that, what are the essential services that the public health provides, what is needed for providing these good public health services. Once we have that well ingrained mind, then we can look at what have been the successes and failures for tackling this COVID pandemic, and how well have we tackled the non-COVID related services. And then I give a slide on way forward. The non-COVID related services, we have eminent speakers, so I may just give one slide or so. So what's public health? Just to remind, it's art and science for preventing disease, prolonging and health and promoting health. But importantly, it's an organized effort of the whole society. Only then we can think about public health. So look at this number of stakeholders to have a good, successful public health related services. So public health agencies at the center of it. Then we have doctors, hospital, laboratories, fire, transit, elected officials, and so on. And what essential services are part of the public health? To monitor health status, to diagnose and investigate problems, inform, educate, and empower people, mobilize the community partnership, develop policies and plans, enforce law and regulation, link people to needed personal health services, ensure competent personal healthcare workforce, evaluate the effectiveness, accessibility, and of course, carry out research for new insights. Okay. There are 6 key areas which are required to succeed in public health. Center of it is innovation. Let's not ever forget that. Surrounding it is the political commitment. And then we have technical package, communication, management, and needless to say, partnership. A mnemonic of 6 S's is put by the NHS in UK: stuff, staff, space, system, surveillance, and society. So what are the success stories that we have seen during the pandemic? Something which I say now are actually already well known to most of us or all of us, anybody who sees the television. Importantly, we have a shortened time for innovation to reach the society. Wonderful. That's a great success story. Everybody's familiar how quickly the government and government organization and private companies have been able to provide ventilators, not only to this country, but also to the other countries. Needless to mention the robots for sanitization. So in that stuff, we had this accelerated production with DRDO, BHEL, and the private and personal protection equipment was through the Atmanirbhar program was developed. Then we have innovated quite a lot on repurposed drugs and, of course, development of vaccine, needless to say that. If we look at the global trial registered, and this is not even up-to-date data, maybe 3-4 months old, total trial register are 3,000. Oh, some of these are observation and so on, but with intervention, nearly 1,000, out of which there are 300 or so with new different drugs, and through 100 and odd countries, enormous amount. But a bit of, I would say, not all, but bit of India is, look, we don't have that many studies really launched. We could have done a bit more than what we've done. Look at the yellow color for the USA. We are still in a bit of a dark blue color. One of the, I would say, not exactly a failure, but a matter of concern has been different clinical trials have used different outcome indicators. And that has confused us quite a lot. Though some of them seem to be requirements. So we had like viral load was one, time to clinical improvement, time to hospitalization, improvement in clinical status, mortality, and then oxygen saturation. The whole world knows how to do oxygen saturation. So we had a whole lot of outcome indicators as a part of all these studies. And every company with a new drug or a repurposed drug used the right one for their own benefit, sometimes not necessarily of the most public health interest. And we had these top 30 drugs in clinical trial. A large number of them were done initially on hydroxychloroquine, but as things moved on and more expensive drugs started coming in, these paled in the background. Now, I don't want to talk about whether we call it as failures or truth or what, but some of the outcomes and some of the publications were usually skewed because of the fundings and because of the politics, whether it was between companies or whether it was between nations. So this is a Sankey diagram for the country and drug development. You can see a large amount of coming from the United States. A number of countries have been shown here with what they focused on, and this is taken from literature. The contribution from India was really not enough to put it in this. Now, there are some areas where we can say we have been successful in some way, but there have been some failures also. So I'll just cover quickly these areas: vaccine and infodemics, and society, media, staff, space, system, sustainable development goals. So when we talk about vaccine, we have succeeded immensely as a country and as an international organization in developing very large number of vaccines which have been tested, and they have been brought to actually public health use. But adverse event has always been an enigma. In fact, in public health programs, and Dr. Ganga Khedkar and others who are in this panel will remember that 15 years back, they were all used drugs or used vaccine with great deal of experience. And therefore, in public health program, there was a bit of a reluctance to mention and report adverse events. And one would tell the user that, oh, this is very safe, don't worry, take it. So that was the kind of approach that we had. So much so that 15 years back, WHO came out with a specific technical report, which I initiated, that is the safety of medicines in public health program, how to go about with that. And later, a few years back, we also came out with prevention and management of EDAs associated with anti-tubercular drugs. So if you look at broadly the vaccine acceptance, there are some who will unquestionably take, then some who have a cautious approach, some are hesitant, some will maybe selective, and some will not take the vaccine. And part of this vaccine hesitancy is because of concerns about adverse event following immunization. And now this concern comes up as a conglomerate of various issues. We have subsequently a whole lot of panel discussions on the psychosocial aspects of society overall. But people are concerned. It depends on their past experiences, what they hear and what they read in the newspaper and what they see in the media. Somebody whom I know, she said she was not going to take vaccine. And when I asked her why not, so she said that vaccine will make her put on weight. Now that was the most unusual adverse event I'd heard of. So I said, what makes you think so? And she said that's because when she took hydroxychloroquine July, August, she put on weight. So now she thinks that with vaccine also she'll get. And I thought that the reason was because she was under lockdown and not exercising enough was the real reason. So causality of vaccine adverse event is a big issue actually. Possible types of AEFI, as we call them, adverse event following immunization, it can be just death or life-threatening event like anaphylaxis, hospitalization. There are possibilities of programmatic errors of immunization. A whole lot of effort has been done in this pandemic to avoid programmatic and immunization errors through a lot of prior trial runs and so on. People have anxiety, there are clusters, and some times an issue about product quality, though we haven't really had any issue like that. And we have some which are with unknown causes. So if you see the UK yellow card reporting system, where doctors are expected to report if their patients have any adverse event of concern to them, then out of 10 million vaccine is done, the yellow card reports have been to the tune of 50,000. And through that, each card has more than one. So about 10 lakh AEs reported, out of which 200, 700 have been anaphylactic reaction and about 200 deaths. So this is the UK yellow card reporting system, a very well mature system running over past 3-4 decades. We've all been hearing about the news now about the blood clots. And now this is a report which I've taken from the EMA, European Medicines Agency. And rightly so, what they've said is that normally in the population, you have 300 to 650 per 10 lakh population. And now out of 17 million vaccinated, we have about 40 people following COVID vaccine who have developed these blood clot related problems. So the question has been, is it causally related to the vaccine? The jury is out, one may say, but by and large, people are saying this is not causally related. Pros and cons to it. How does one know whether it is causally related or not? Well, it should be temporally related with a biological possibility. So if it occurs 6 months later, we would say very unlikely. If it occurs immediately, we may say, because the biological causes for any A2 vaccine, there are several. I'm not going into the details due to a short of time, but there are many causes ranging from antibodies which are acting against similar or other other biological systems, or it may be on account of, as we call as molecular mimicry, and so on. The way to look at it is also if that adverse event is something very unusual. That is, normally say it occurs at the age beyond 45, 50. Suppose suddenly somewhere at young age you get it. We are seeing in children, and Dr. Sachdeva might like to comment on it, COVID-related vasculitis. If the pathology is something really weird, very unusual, then you might wonder whether it is related to the vaccine. Doesn't seem to be so. Normally, for assessing causality of any drug, what we do is group it as de-challenge, re-challenge. That means if the drug is withdrawn and the adverse event disappears, we can say reasonably that it was related to the drug. Or re-challenge. By mistake, if somebody takes it again and it reappears, then we can be pretty sure that it is on account of the drug. But this is not done ethically. And so this part of our way of assessing causality always remains a bit conjectural. So what is the system for adverse event monitoring in India? There is an AEFI reporting and analysis system under the Ministry of Health and Family Welfare. This has been essentially developed for the vaccination in children. And Dr. Sachdeva have been very actively also involved in this. And this system has been there. But it is for children. So it had to be modified entirely for now adult, and that too senior adults. So in that now statewide and local committees have been established with many other experts in that. Then we also have this Pharmacovigilance Program of India, which is under the Indian Pharmacopoeia Commission, also ultimately under the Ministry of Health and Family Welfare. Now these two have to be linked. That is the PBPI, which mandates for pharmacovigilance program everything, all drugs, blood products, vaccine, everything comes out, even herbal products, all these come under the PBPI, and the vaccine related, which is with the AFI, that gets linked. Then we have the CIVISCO, which is the regulatory authority, and then of course the industry, which has a keen eye on what's going on to their adverse events. So this is the system that has been developed for the adverse event monitoring particularly for COVID. And so there's a case reporting form and then case investigation form. And the people responsible are the medical officers and the district immunization officers. You can see that there are timelines, and you see the right-hand side column. What will you see? That the case reporting form, that is the notification, happens very quickly within 24 hours. But then it takes a lot of time for the actual investigation to be completed. By that time, the whole thing is out into the media. And that is where a bit of confusion occurs, because when it comes to media, it is still not gone through a complete process of assessment and evaluation. And so this kind of causality, case from case notification to causality assessment time, it could well be a good 100 days going through these various steps before decisions are made. But these days are compressed and try to come out quicker if there is a reasonable doubt that it could be related or not.
Madam, I
Then-
hate to interrupt you. Madam, I hate
Yeah.
to interrupt you, but I just want to inform you that your 15 minutes are over.
Okay, I'll quickly go through the next 3-4 slides. And then we have this connection between the AEFI and the PVPI, as has been shown. What about the society? We all know that along with news, there's also information which is created through the TV. Staff, we want that the recruitment, retention, redevelopment, retraining, everybody has applauded as the person of the year. New space is created, there's reallocation of space, there are apps which are created for non-COVID services within cough, cold medicine and personal hygiene product, as we can imagine. Rest of it is all what will be covered by others for panic buying of ICU medication, etc. And their own share of problems of approval delays and also growth slowdown and so on. SDG, Sustainable Development Goals, I won't go into that except to say that there has been an impact of this on other immunization in children, and this global data shows that there has been an impact on especially the pediatric population. There has been a decrease in the visits to hospital, OPD, but telehealth has increased quite a lot. So what's the way forward? From the lesson learned, we see that there has been realization that there is a need to strengthen government system, and also realization we need to strengthen the clinical research and drug development in the country. A real-time data availability needs to be strengthened so that the simulation organization like IIPS does is more predictive. And of course, the risk and benefits specifically for the elderly with comorbidities need to be analyzed so that we have specific strategies for them. Thank you very much for your attention.
Thank you so much, madam, for summarizing the successes and failures in the COVID era and showing how for certain things the challenge has been used as an opportunity. Thank you so much. Now I would like to invite Dr. Singh Mitra Pati, who is the current director of the Regional Medical Research Center of the Indian Council of Medical Research at Bhubaneswar, Odisha. She is a physician turned public health researcher who has had her MD in Odisha and MPH from the Netherlands. Since August 2016, she is the director of this RMRC. Her area of interest has been the magnitude and outcome of morbidity and health system strengthening. I invite her to speak on challenges in managing chronic diseases at the time of pandemic. Dr. Singh Mitra Pati, please.
So is my screen visible? I cannot.
Madam,
Yes,
just
ma'am.
open the PPT only.
Yes, is it visible now?
Yes, ma'am. Yes.
Should I? Is it in the slide mode?
Yes,
Yeah,
ma'am. It is in slide.
It's fine, madam.
Sir, good evening. Sir, is it moving? I just want to check before I go. Is it moving?
Yes, please.
Okay, sir. So, esteemed chair and all the distinguished panelists and of course the audience. So first of all, thanks for making me a part of this panel. And Lima ma'am has made my job much easier by speaking on the non-COVID services and how they got affected at the time of a pandemic. Sir Basically, initially before joining ICMR, I used to be more focused on chronic diseases, but after I joined ICMR, I transited to infectious diseases because of laboratory work at RMRC and also addressing various outbreaks and infectious disease pathogens in RMRC. So basically what we have been looking at is the interplay of chronic disease with infectious diseases. So everybody is well aware when the COVID-19 pandemic started, the most vulnerable were told those who have comorbidity, those who have diabetes, those who are obese, those who have hypertension or on dialysis. So basically we identified a list of comorbidities who are more vulnerable to COVID-19. But at the same time, there is also a bidirectional association, like those who are having this kind of chronic conditions during COVID-19, they might have some kind of care challenges because all of us are well aware that chronic diseases, by the name of their chronicity, they require a continuum of care. And with COVID-19, because all of us know that the COVID-19 pandemic has led to a very, very quick transition. In fact, every hospital was made to ICU, then ventilator, the kind of emergency preparedness had started on war footing board almost all the hospitals. And the focus moved very quickly from chronic or slow-paced care, usually along with emergency, to complete emergency, and not only emergency, but also high level of biosafety. Because every patient was kind of thought of whether he or she could have COVID-19, and at the same time, patients were also little apprehensive whether hospitals were the source of COVID-19 infection. So with what this pandemic did is that it not only made a very quick transition from non-COVID to COVID care, but majority of our healthcare resources were also configured or focused on COVID-19 management, and that was the need at that time. How do we save lives? And while saving lives and while putting more of our resources, our focus, our strategies, our plans, and our human resources on addressing COVID-19, at the same time, this resource reallocation would have affected the continuum of care for those patients who are living with chronic diseases. So basically, whenever there is any chronic care or any illness care, three are the stakeholders. I mean, ma'am has showed a very beautiful diagram of all the stakeholders. When we compress them, patients are the most important. At the same time, service providers and health systems. So basically, chronic care is a product of the collaboration or the interplay of these three key stakeholders. So we wanted to find out, because we knew that diabetic patients are more vulnerable, but at the same time, how do these diabetic patients manage their routine diabetic care? How do these chronic kidney disease patients manage their dialysis needs during COVID-19 pandemic? So we undertook a study. I'll be just describing briefly our 4 studies, which we did at the time of a pandemic. We did it just at the end of the first lockdown, that is May to June, in Odisha. In fact, RMRC Bhubaneswar is located in Bhubaneswar, that is in Odisha. So we did in Bhubaneswar because Bhubaneswar was the first airport entry for Odisha and was the most affected district in Odisha. So we wanted to see how the pandemic preparedness and the COVID-19 services has affected the non-COVID services, particularly those who had comorbidities or chronic conditions. So we used, what we found is that, in fact, this is submitted and in fact accepted by Indian Journal of Medical Research. So we looked at the NCD care during COVID-19 pandemic, and we used a mixed method study, which has got a quantity as well as similar. We also had few open-ended and qualitative component. So what we found is that the major challenge people had in terms of diagnostic services, because they were not sure where to go for the routine blood checks, where to go for their blood sugar estimation, where to go there for all the diagnostic services, followed by financial arrangement, because many, as we know, because of the lockdown, many were also wondering whether they can spare their finance to go to hospitals. And most interesting finding that came, which maybe before it was not there, people perceived hospitals as a source of infection. They were scared to go to hospitals. They tried to manage the illnesses at home rather than visiting a hospital. And another thing they also found problem is that getting an escort to accompany, because many did not want, because of the social distancing, because to accompany hospitals, many did not want to be the accompanied. And getting medicines and doctor consultation was also another challenge, getting transport arrangement, and of course, because of the social restriction. So then what we did is that We also saw that it is when we compared between one condition versus two conditions, those who had two conditions, that is multimorbidity, they had much more challenges when compared to single condition. In fact, those who had two or more conditions, they had the odds of getting higher care challenges was 1.48 times more than those who had single chronic conditions. And here also, the major concern was because they were having multiple and sometimes conflicting chronic conditions, for example, diabetes and kidney or or say, for example, arthritis, coordinating between two physicians was also getting a challenge for them. So this is what when we looked at, like we did both urban and rural, so versus single and more than one NCD or multimorbidity, when we see that, for example, the last one, or when we look at the percentage, we see that those who had got two or more, and particularly urban and rural, when we compare, that was more challenges. In urban, those who are living alone and those who have mental illness, they express that their challenges were more to access care compared to the counterparts. So when we found out that those who were older adults, those who were living alone, those who were urban resident, and those who are having mental illness, these are the four groups which emerged from our study, who are having higher care challenges compared to their counterparts, and at the same time, they had more problems in terms of diagnostic services compared to doctor consultation, because they could call their doctor up, but they didn't know where to go for the investigation. And 38% of our interviewee experienced that they had care challenges, some kind of care challenges, and these care challenges span from having an appointment with the doctor or access to medication or investigative or doing a daycare emerged to be a very strong challenge, particularly dialysis and chemo. So that in fact, dialysis was the major reason for many priority patients. They wanted to get the COVID-19 testing done immediately because they had to undergo dialysis, and no physician was ready to do dialysis without the COVID-19 test. So they had a very significant care challenges. And fifth was that those who were not having COVID-19 but simulating COVID-19 symptoms, like for example, acute myocardial infarction, or those who were having COPD. So getting emergency care and then also proving that or doing a test and COVID-19 negative report, getting a COVID-19 negative report at the right time was proving to be a challenge. Transport, and of course, so many preferred to delay in seeking care rather than going to the hospital. And after looking at or after seeing that the older adults and those who are having mental illness, those who are living alone in urban residential area, we did two qualitative studies. So first we looked at older couples who are living alone and how they were managing through the pandemic. But we had a very interesting finding. We saw that, over a period of time, the older couples have found out the ways to emerge stronger, to emerge resilient, and to find out or harnessing their own resources. In fact, they try to marshal different networks, different resources so that they can manage through the pandemic. And when we analyzed this qualitative data, we found that there were 4 levels of conducive elements for coping through the pandemic. One was individual inner strength of their family environment, how congenial that family environment was, how cohesive their social network and support. Many told that they reconnected with friends, then their neighborhood community provided them some protection and support because they knew that they are living alone. And third thing what they appreciated is that adaptive organizational change. Many organizations started making some adaptive change, like, for example, few hospitals started teleconsultation, few laboratories started. Initially, there was disruption, but slowly people started adjusting to the pandemic response, at the same time trying to provide the continuum of care for other conditions. Hospitals started teleconsultations, laboratories started providing home collection for test sample, pharmacies provided home delivery of medicine. So these are the small changes, but that really helped these people to manage through the pandemic. And most important, what was found is that the responsive administration and policy. In almost all the couples, they expressed that they have received a very good or a warm or a cordial response from the local administration and policy support. For example, They were essential services, like they feel that it was maintained, then facilitated healthcare like ambulance services and helplines were there. Then popular television programs made them to be engaged, and they were constantly kept updated on pandemic status. And they also started adopting slowly, but they slowly adopted pandemic appropriate behavior, because I still remember one of the people told that we wish to live longer. So we also have to protect ourselves, because we also yearn to live longer together. And most stressful for them was that maybe if at all one spouse gets infected by COVID-19, how they will manage. So that is the reason they try to support each other, they try to protect each other, and they try to sail this storm together. That was our major finding we found, particularly strengthen spousal support, and they reset the priorities of life. They rediscovered some rediscovered their hobbies and rejuvenated relationships. It was some kind of collateral surprises were in store for us when we went to explore the qualitatively how these older adults or couples managed living alone throughout the pandemic in an urban lockdown time. Then we also saw the what would be one of the suggestions was that patient activation was very important, because slowly these people started activating themselves. They became more proactive, and they started some kind of engagement with health promotion. Even if they could not go on morning walk, they tried to do some physical activity at their home, and they kind of believed in the pharmacies, so that the pharmacies could arrange the blood collection. So a community pharmacy model could be thought of, and we can also think of a family-centric and a home-based chronic care delivery model, because we never know another pandemic or another public health emergency may strike. But how should we prepare this kind of alternative models ready, so that whenever there is any urgency, they can come to place?
I hate to interrupt you, Dr. Pati, but
So
I
this is the
wanted
last
to
slide.
inform you. Yeah, thank you.
So this is what we did, is that we also wanted to see, because the psychiatric illnesses was found to be the strongest challenge during COVID-19 pandemic. We just explored the caregivers' experiences. How did they manage dementia care during COVID-19 pandemic? So what we found is that the caregivers were not worried for dementia or managing dementia care. What was more bothersome is the coexisting chronic conditions, because they thought, since our parents or our relatives are having dementia or are old aged, they may get COVID-19. Then what we will do, because a dementia person cannot take care of himself or herself. So that was the stress always kind of affecting, or constantly they were apprehending that because a dementia patient cannot take care of himself or herself, if that person gets COVID-19, what we have to do. So they try to take utmost precaution, not only for themselves, but also for the person concerned, so that he or she does not get exposed to any person. So what was the implication of our 4 studies was that public health response plan must embrace chronic care needs to address the challenges during any pandemic or emergency, and provision of chronic disease management has to be configured so that the major care disruption does not happen. And both physical and mental health care is extremely important during both pandemic and post-pandemic exit plan. And digital healthcare, we found people used teleconsultation, and also we can think of community activation for home-based care. Thank you, sir.
Thank you so much, Dr. Pati, for outlining the challenges of chronic care in a pandemic-like situation, and suggesting potential ways or models to look at during such exigencies, which could come handy later on, and even now the epidemic has not finished as yet. Thank you so much, madam. So next, it's my pleasure to invite Dr. Ramana Kumar Agnihotram, who is the Associate Director of the BCU Core RIMUHC Adjunct Professor, Department of Oncology at McGill University Global Leadership Panel. Dr. Raman has extensive experience in cancer epidemiology and public health. He has previously worked with the WHO on global cancer surveillance and survival projects. He is currently associated with various national and international cancer programs. He has published more than 120 peer-reviewed research and acted as a course instructor for a 3-credit course In his career, Dr. Raman has mentored several trainees, graduate students, and research staff, and managed several projects in structuring, standardizing, and streamlining scientific and budgetary matters, and also participated in crucial business decisions. He will be speaking on the impact of COVID-19 pandemic on cancer diagnosis care. Dr. Ramanna Kumar Agnihotran, please.
Thank you, sir. Thank you, Professor Sachdev. And can I have the share rights here? Yeah, thank you very much. Okay. So can't I share from my side, sir?
Yes, sir.
Yeah, it's not activated, the share content. Thank you. Screen one. All right, thanks. Thank you. I would like to thank Professor James, Professor Nisa, and all my teachers at IAPS and friends. The next few minutes, we're just going to, okay, you see the slides there? Thank you.
Yes, yes.
Thank you. Thank you. And here, just, since the inception of this COVID-19, there are about 2.7 million deaths, and we all know that there are more than 120 million people infected. And the first wave of the infection is a big blow because we are not prepared for that. Most of the health systems are not ready. So we undergo, most of the healthcare services across the world, they underwent immense stress. It's like a stress test for an entire system to cater the demands of the patients from the COVID-19 exposures. And the institutions has to work really very hard to reorganize their resources and human resources as well as equipment. And they have to find extra intensive care beds, as well as they have to convert some of the ongoing care services into COVID services. For example, they had to change the oncology wards, veterinary wards into COVID wards. And also, initially, the staff were not available because most of them, they got infected and they are on isolation. So there is a scarcity for PPE equipment and other equipment, and all that, we went through those conditions across the globe. But there is also a lack of science at that point, very early days, particularly in the first wave of the infection. It took some time to identify most of the established risk factors. Of course, soon we realized, and then some of the risk factors already mentioned by the previous speaker. So cancer is established as one of the risk factors. Why I had to mention very specific to this condition, cancer, because that cancer, even before the COVID period, we are dealing with a situation to tackle the cancer burden across the globe. So I just mentioned that we are about like 3 million cases that died of COVID deaths. However, every year we have about 9 million deaths due to cancer globally. And most of them would have been avoided because lack of resources, and most of the deaths happen to be in some of the low resource settings. And otherwise we would have avoided some of these deaths. So, and also, as I said, like the situation for the funding situation for cancer research and cancer across the globe, not just in North America, is on slightly downtrending because it's already at a very high level in the last decade, and then it's on the slightly lower side before the epidemic. So we know that we are going to deal with already a very stretched situation, but this happened. The COVID happened to be in the middle of March, exactly the budget time where most of the governments are really working hard to approve a cancer-related budget, but then the COVID pandemic has taken away some of the resources. And so it really poses a very difficult situation in many ways. And also the isolation and physical distance and some of the cases, care was either delayed or denied in that situation. So when it comes to the cancer, there is a problem. The clinicians has to weigh between two different things. One, whether should we delay the care for a while, and then because just to avoid exposures. On the other hand, by avoiding this, we are also creating some damage, colorectal damage to the cancer patients and the system itself in long run, in terms of survival, in terms of excessive risks and deaths in coming years. So the post-pandemic period is going to be very different because we have to deal with the excessive amount of mental health issues, excessive amount of non-communicable diseases and cancers, etc. So we started estimating what may be the impact of the COVID-19 pandemic on cancer itself. So there is I'm just trying to put together, and then we will present our own results as we go. So one of the very renowned simulation studies from the UK that shows, a slightest delay of about 3 months may cause a substantial increase in kind of avoidable deaths. And it is always, cancer is always terms in terms of specific sites. So we can say breast cancer about 10%, lung cancer between 15 to 17%, and in esophagus cancer, it may be like 5%. So we still don't know wide spectrum of other sites, what may be. So here there are two, the theories are there. There is a COVID risk and then cancers. These two are the competing risks. We know that the people, particularly cancer patients, they're at risk for COVID infection because of compromised immunodeficiency, and because the disease itself, it could be the immunocompromisation may be induced by cancer treatments or maybe a malignancy itself by nature. And also most of them are with comorbidities, particularly obesity and diabetic or other comorbidities, which are already known as established risk factors for COVID-19 as well. So, and also they need to go for like a frequent hospitalizations are needed, frequent visits of ICU wards are needed. So that may allow them to have more exposure. This is one side of the story. Another side, that's how we have already COVID risk, and people were infected, and people were really, because of the interventions, they were isolated and diagnosis being delayed. So that halts entire screening program in well-defined, like, where you have screening programs, well-defined screening programs, 5 to 10% of your case identification is always through the screening programs, routine screening. And also the diagnosis delays may pose a variety of adverse factors in the long run, which we need to know. And also there is another theory, because of the COVID, we have a hyperactive immunoactivity going on for different cells. So in long run, they may trigger some of the dormant cells to get reactivated or reawakening these ones, and may pose as an onco transformations or in long run. People started looking at this hypothesis, but we need some time to understand this hypothesis. But we look at some of the studies before looked at the risk of activating these neutrophil extracellular traps like NETs, and the risk of breast cancer and lung cancer. But there is a high risk of resurgence or recurrence of the cancers that's been under study right now. So just to know a little bit about what's going on with epidemiology, we have two ways people looked at this, and they looked at the incidence cases of COVID-19 among the prevalent cancer cases, and also they looked at the other way, taken all the COVID cases and then looked at how many of them do have the cancer. So these are the two competing risks. They carefully trying to understand where it is, but the range is very wide. You look at some of these published results from Austria that just says, okay, the risks are very similar like general population. We don't have an excessive risk of COVID incidence among the cancer people compared to the general population. But the same thing, but it's not consistent with the US studies. A large scale study based on veteran affairs, they report about 8%, and also they have racial disparities between different ethnic groups. So The early, particularly, there are other studies particularly focused on the high-risk groups like hospitalized patients and ICU patients that reports about 6 to 8% excessive risk compared to the general population. So overall, if you look at the evidence put together, entire evidence from the large-scale population-based results that have been published so far, we know that there are excessive risk of, this is a study put together 8 different studies. The pooled estimates come out like 66% excessive risk of all-cause mortality among cancer patients compared to the non-cancer patients. So it's been a very solid evidence that cancer being serving as one of the risk factors within the COVID spectrum. But the results are not consistent across all the sites. But what we summarize at this point from the evidence, what we have is the lung and hematological cancers are at definite high risk of the mortality, either in short run or in long run, but we have to wait for some time to really study the long-term effects. So, but also the study, because most of these risk ratios and other odds ratios being adjusted for all confounding factors. But in general, older age and obesity and advanced disease are coming out like modifying factors. Some of the very important points, just I mentioned, like screening is one of the very important factors. We have some evidence across the world, but from the societies where there is an organized screening going on, very strong screening programs are in place. We can see one of the studies that come out of the US population that says about 85% of the screening programs on heart, particularly for the breast cancer, colorectal, almost like 3/4 of them, and then breast is 5%. Our own research shows in Canada, almost one of the states, Ontario, we don't have this information from the rest of the places. But what we know from these organized programs are 97%, almost breast cancer screening been on halt for some time. Particularly, this evidence is from up to June or July last year. So, so we can see that there's a huge percent. Our estimate in our population, so we come out with, we have about 55,000 cases in general. So we have about 78% of the cases that are missing just because of drop in the screening programs. The screening effects been studied in a kind of most of the simulation situations. They are like a mathematical model and statistical model, so they fitted and they come out with a large scale impact. I mean, large scale in sense, you see like we have about 2,200 cases, excessive cases we project, which means we have about 226 cases. That means 226,000 cases per year. So we have more than 1% addition of these cases just because of small delay in about 3 to 6 months in the screening program. And so most of the studies are in the same line, so I don't want to stretch on that. For the cancer diagnosis, we look at the our own data, local Canada. So soon we are going to come out with the national statistics, but we have data emerged from some provinces. It comes out like, one of the states like Alberta in Canada has about 23% underdiagnosis. This is published data from March to September last year, and British Columbia is 25% underdiagnosis of the cancer diagnosis in this period of lockdown period. Most of the period is lockdown, and there is some provision. And then look at the Quebec data. That's about, this is from our study, like 22% of them like underdiagnosis right now. In MUHC, that's the Montreal University Health Center where I work, it's one of the major hospitals in our province. The new patients are like, they're down by about 22%, and surgeries are down by 11%, despite of having telehealth and other advanced platforms to deal with these things. And overall, there are 54% of cancer case appointments being canceled and scheduled or postponed at this point, and then 75% of them are really newly diagnosed patients, which is very, very alarming situation for me. And the treatment delays, we can say, like, of course, the treatment delays over a period of time, very, very important. This is something, one of the studies from the UK, which is which is very eye-opening. If you look at these are the entire services, cancer service, and this is a chemotherapy service here in this. You can see that the yellow period is like a pandemic period, it's just gone down and then slowly recovering in the post-lockdown period. So what we see here is that always a delay of, it's just a 1 week delay in the treatment increases the cancer mortality in a range of 1% to 28%. That's very concern for us. And also there is an 8% excessive mortality due to breast cancer surgeries itself. So the worst is yet to come. So we are just trying to project what's really going to happen. So, the previous speaker just mentioned about the COVID-19 trials, but here I just try to mention what happened to the cancer trials, so that there are about 60% of these clinical trials across the globe on cancer for the cancer drugs and biological therapies has come down during this pandemic season. That's a big ask, because the drug cycle takes long periods, 7 to 12 years. But if we are dealing further, probably we may have to deal with certain drugs, particularly in some areas of oncology. So there is a 10 times drop. You can see here this statistics like there are 1,249 trials launched in oncology alone before the COVID, and now we have only 191, which is like almost 8.5 times down there. And also a very critical point I just want to mention here is the charity. In certain societies, OECD countries mainly, the individual research, depending on most of the clinicians, they perform the clinical trials at the hospital level. They're initiated by the physicians based on the charity grants given by the patients and the ex-patients and the public. So there is a tremendous reduction in the charity over a period of time. And particularly last year, it went down because people are only dealing with their own financial crisis. So they're not in a position to give a charity. So there was a tremendous reduction in the early 2020. So that may lead to put a halt on some of these clinical trials that are planned. So
Dr. Ramana, sorry to interrupt you, but I wanted to inform you that your 15 minutes are over.
Yeah, I'll summarize.
Can you please hurry up? Yeah,
sure. So we come up with a population-based surveillance data with about 5.1 million catchment population, and then we looked at because here we have a provincial health plan, so we don't have to really think about health disparities. So what we did was we created a reference period, like an average of 3 years before, from 2019 to 17, with a base period of 2019. And then we have taken the weekly data over a period of time, and then we fit a Poisson model for counts for each of these weeks. And then in the next step, we consider like incidence rates from 2 different periods. One is the reference period, which I just mentioned, and then comparison period is just exclusively for this period of 2020. And then we did incidence rate ratios, and then we come up with underestimation of the cancer diagnosis, particularly in this period. So we run other models like autoregressive ARIMA and S models. So we come up with, in summary, what we say here, looking at all the sites, we have about 30% cases that are under diagnosis. And then we ran these Poisson regression models, and you can see here, this is the estimated model run from the time series analysis, and these are observed cases over a period of time. This is the data is, as I mentioned, spanned between April to August, and you can see the first few months is really wide. So when we looked at it, the IRR, so incidence rate ratios, compared to 1, which is a reference period, we have about 27% underestimation among female, as well as about 24% male. The same thing, we observed there is about 30% underestimation in the age group like 50, and more or less consistent underestimation about 26 to 27% in all different age groups. And there are regional differences. You can see from here, the tighter intervals, what you see, these are the confidence intervals from the IRR. That's are very tight. Those are urban populations with a very high quality data, but this is like there's a bit. This is because of the data quality from the rural areas. And also a very important point, just one point here, the red zone, orange zone, and green zone, just depending on, this is very similar like what we have in India. So there is no big difference. So the site-wise, one really striking point is breast cancer is one of them. And then there is a close gap for the lung cancer. So you will see the difference between these things. So with that, I thank the organizers and thank you, Professor.
Thank you, Dr. Ramana Kumar, for outlining the issues with the cancer during this COVID epidemic, both that it increases the mortality and COVID could have an effect on this. And now, last but not the least, it's my pleasure to invite Padam Shri Dr. Ganga Khedkar, who everyone who actually does not need any introduction. All of us are aware that he has been the face of the COVID response in the entire country. He is currently the CG Pandit Chair at the Indian Council of Medical Research and was earlier the chief of the Epidemiology of Communicable Diseases Division as well as the NARI at Pune. Dr. Ganga Khedkar will speak on SARS-CoV-2 variants. Dr. Ganga, please.
Thank you, sir, for the kind words that you used for introduction. We are going to learn something more about SARS-CoV-2 variants and perhaps its own implications. I'll try to quickly go over the slides. Now, one of the things which we need to understand is why do these viruses mutate? We need to understand that this is a battle royal between living organisms, including viruses and human beings, for survival of the fittest. But all of them know that if one side has a complete supremacy, perhaps it's also a death sentence for the other. And therefore, when viruses would like to mutate, what do they want to produce? They want to reduce their virulence, they want to enhance their transmission efficiency so that they can survive longer. And in addition, perhaps some of the viruses would like to find an ideal sanctuary or a reservoir to go for latency where they can sleep. The symbiotic survival is perhaps through a nuclear deterrent, that is mutation, that tends to occur, and the immunogenic responses that a host has. So both play the nuclear game very strongly. Why do we worry about these mutations? Because they can generate escape mutants, which may make these vaccines ineffective. You would have reinfections, which tend to become more common. The virus may stay safe in the sanctuary and attack whenever the host becomes weaker. It's like a guerrilla warfare. And rarely, it may increase virulence and impact the case fatality rates. It may lead to a long-drawn battle because you will have to develop newer drugs and vaccines in your arsenal, which may remain valid for only a short period of time. If you look at the transmission dynamics of this virus, the virus mutates very slowly. Compare it with influenza and HIV. But the virus needs a human or an animal host to survive. The usual span of this virus in the human body is only about 2 weeks. And it's such a small duration that perhaps the virus was expected not to develop so many mutations because there was not much of selection pressure that it would actually be witnessing once it enters into the body. But the virus has surprised all of us. The virus is likely to establish one mutation every 11 days in the population as its normal rate. We know that the spike protein was one which was fairly conserved if you think in terms of its comparison with other coronaviruses. But within 15 months of cohabiting with human beings, you find that the virus has accumulated 17 to 23 mutations in the entire virus. And then if you look at spike protein, 8 to 10 mutations, spike protein is far more important for all of us. Then why is this virus mutating? This virus may be mutating because of selection pressure. Now, this could come from antiviral drugs, but we know there are no effective antiviral drugs. It could come from immune pressure, and this immune pressure perhaps has played its own role because we used convalescent plasma. There were different spectrum of neutralizing antibodies in varying titers to which this virus was actually exposed to, and this may have had led to perhaps development of mutants rapidly. And it also tends to increase its lifespan by living in people who have immunodeficiency or old age. So their immune system allows the virus to survive for a long time, giving it an opportunity to mutate. The viruses are just like us. No, we know our physical life is going to be short. And how do we try to immortalize ourselves? By ensuring that our genes tend to go to the progeny and we survive. The same thing happens with the viruses as well. What viruses do is they will continue to replicate even if there is an error-prone reproductive pattern that you might see because of the enzymes which are defective. But it would like to occupy different bodies as quickly as possible so that the mutations that tend to occur will ensure that they will happen rapidly in high incidence settings. Now, newer variants that are of concern as of now, 3 which we know mainly, one from UK, one from South Africa, and the other from Brazil. You find what is the biggest worry. No, the UK variant is now known to cause increase in transmission by over 50%, and it increases mortality by over 30%. The rest of the mutants we don't know, but South African and Brazilian variant, as well as E484K, a mutant that we are finding in India, can impact partially the vaccines to a larger extent. Now, if we want to look at the evidence, if you look at what mutants are doing, if you look at the middle picture of pseudovirus neutralization, you find that whenever new mutants are getting detected, there is poor cross neutralization that tends to occur. So you are getting a warning from the virus that I'm going to mutate faster. Now, do we know whether we have such mutants? We started a genomic surveillance in March 2020 under ICMR, which was subsequently shifted to NCDC. It was expanded there. We had a very large caseload, and compared to that, our numbers continue to be smaller. So there is a larger amount of uncertainty. You may find different kinds of variants, but these variants have actually come from the travelers who came from international sites as such, and they were isolated. But what are the ones that are being developed as of now? You look at the spike protein, you find there are 2 important variants that are emerging, and the 681 variant that you are seeing is one of the commonest variants that is occurring currently in Europe and USA. Perhaps there is a risk that our numbers may also jump up equivalent in a short period of time. Certain facts that we must remember. Spike proteins tend to bind to the ACE2 receptor to enter pneumocytes, so they become extremely important. Most of the vaccines are based on spike proteins, excepting few like Covaxin, Sinopharm, and Sinovac, where they are using whole inactivated virions, so they may continue to remain effective against the viruses to a lesser degree, but the efficacy may be compromised. But the other entire strategies are around spike protein. Now, these vaccines, if you actually look at it, they're not perfect vaccines. These are first generation vaccines. So they protect you against severe disease. But do they provide protection for rest of the objectives of a vaccine? No. Does it stop transmission? More inefficiently than we can imagine. If you look at the evidences that have emerged, you look at 2 vaccines, Novavax and Johnson & Johnson, you find their efficacy, which was, let's say, for Novavax 89%, for wild type virus. For South African variant, it comes down to 50%. Same happens with Johnson & Johnson. From 85%, it comes down to 57%. So it essentially means the efficacy suffers when variants develop, but there is a hope. you have too many vaccines, 287 vaccines that are in preclinical development. What might happen, you may have to think in terms of generating second generation stronger vaccines against this particular virus. These variants, if they develop rapidly, what would it mean? You will have to provide vaccine to majority of the population, because the herd immunity concept tends to change when the newer variants tend to come. So you have to do it very rapidly. Ideally, we would require a pan-corona vaccine, if at all. If you look at the impact of variants in certain countries, if you look at Brazil and Poland, you find that it rises up very sharply. The epidemiologic curve rises extremely sharply. So there is a worry that is lurking as of now, where in India, even second wave is probably occurring at this juncture. What is worrisome is partially immunized countries, because we know that vaccine dosages are in limited quantity. This is a globally connected world. So even if few countries tend to vaccinate their own populations as much as they can, the countries that will not be vaccinated would add to a newer selection pressure. Partially immunized world can put up a pressure on the virus to mutate more. And if this is more likely to happen if there is a surge in outbreak and there is partial vaccine induced immunity. So what does it essentially mean? The virus may perhaps go for becoming endemic, mainly because the immunity, whether with vaccine, whether it would be with natural infection, may wane off within 2 years of it, and newer escape mutants would foster the infection. And what is currently seen, which tends to suggest that it is likely to become endemic, you find in UK, when the variant started striking, the population age group tended to change. And today you are getting more of younger age group population, which is getting infected in UK. Currently, the pattern of this pandemic does not appear to be consistent with extinguishing the pandemic sooner. But perhaps like all other coronaviruses, it's going to cause havoc for some time, have sporadic outbreaks later, then become seasonal and become insignificant infectious episodes subsequently. What do the scientists think about elimination of this coronavirus? You find majority of them accept that it is going to become endemic in the world itself. Is there no light at the tunnel or at the end of the tunnel? Perhaps we need to think about it, that today the rate at which we are vaccinating, it would take 3 years to immunize 75% of the population. But we need rapid rollout of the vaccines at the backdrop that 22% of the people were already found to have been exposed in the national sero survey done in December. We need to enhance the COVID appropriate behaviors adherence to right up to 90% and more, strengthen genomic surveillance, develop second generation vaccines which could be effective, and establish One Health surveillance. Finally, what we need to do is embrace new norm to adhere to COVID appropriate behavior irrespective of vaccine status. At least for few years to come, we need to remind everybody that the virus is miles ahead of us currently. Thank you.
Thank you, Dr. Gangakhetkar. You present a little scary scenario, and let me sort of, all right, at the time of questioning, I will ask them. Now I hand over the floor to Dr. Vani Sethi as a discussant to provide her comments. Dr. Vani Sethi, please.
Thank you, sir. Thank you to all the esteemed panelists. I'm reminded of, a professor of mine 25 years ago when I asked him that, all my friends are going abroad to study in famous universities, and you have asked me to sit in the village to do nutrition surveillance. Where will my life take me? And he mentioned to me, follow the professor, not the college. I am so grateful to be in this class of professors, teachers who not only coached me here personally, but today was a master class, free of cost for a lot of people. And this is something positive which has happened in this time where online has become the mode. So I would like to thank each of you for enlightening me. I'm a discussant today because as a person who has been supporting the government in continuity of nutrition services, but also I would like to bring a personal perspective to this, that as a daughter of a parent who got COVID and got services and treated and came back home from AIMS Hospital, so how the public sector helped, and and a daughter of another parent of mine who was suffering from dementia, various COVID, CVD problems, and actually could not get service. So I have been a witness and a victim of this pandemic. As a discussant, I'm going to give some important points, largely for the audience, and then throwing it up for discussion. Dr. Nilima's presentation was spot on, and I would like to take you through the two important successes and failures. I would not even say failures. I think what we can do better for COVID, specifically in public health. She reminded us that it's not only the government, but people in society that play a role. We have been successful in shortening time to deliver. Specifically, she mentioned about ventilators, robots, sanitizers, responding, the staff, what they are doing down in the field, the changing scenarios. She also mentioned that the adverse events in terms of numbers are much fewer as compared to those that have been vaccinated. She mentioned a whole lot of issues regarding vaccine hesitancy, and she expressed her concern that compared to other countries, the types of research and trials that are happening in India, both with types of drugs and the type of research and funding associated with it, needs to improve. She also mentioned that the time delay between the notification of causality and actual case coming needs to be reduced. And as well as she ended by mentioning about real-time data for stimulation being needed, and also analysis of risks of elderly. Moving to Sangamitra ji, excellent work and studies which she tried to present, and I tried to summarize them, all related to the chronic diseases and pandemic. And I could relate to each of them because my late father suffered from several of these. And she mentioned challenges around the care. She mentioned challenges around awareness. People did not know where can they go for diagnostics, and this still remains a challenge. Fear of going to hospitals, the transport problems. She also mentioned that those affected with mental illness, staying alone, are facing problems. But she also mentioned about some solutions which can move, healthcare in the direction of home care pharmacies, home care screening and treatment, and those kind of care models which need to be done, expanded with, and probably health and wellness centers and moving them into telemedicine mode could be the next to study what she has done in a few areas to at scale. I think again, just like Dr. Nilima, she really mentioned about elderly and how such pandemics have affected them, and how they have actually created a social system within themselves. But what more can public health do, and how a geriatric policies need to go? And this is one probably question which is continuously coming into my mind, is that the coping strategies and our geriatric policy of the country, for looking at it more holistically, providing some home care service, how far are we from it? Dr. Raman, I could not agree with you more. He mentioned three important points about cancer and the competing priorities of being treated with cancer, being screened for cancer vis-a-vis COVID, and how care, screening, and treatment actually took a back seat for cancer, which is also life-threatening, and because you have to take care of the COVID situation. He also mentioned some important nuances around, charity, livelihood being affected, and because business communities were largely affected, charity were affected for cancer. He also mentioned about how research in the area of cancer is actually has a 10 times drop in trials and 37% reduction in charity for them. So I have taken extensive notes, but these are some things which actually came in. And I think the presentation towards the end scared me. Just like Dr. Sachdev had mentioned, that away from it now, we have to live with it. And this is a question which colleagues, I was posed even yesterday. I'm a principal investigator of one of the trials, and they mentioned to me that a lot of procedures for face-to-face data collection, and we should wait till the COVID is over and we should not do it. All researchers are getting questioned whether we should continue research, we should stop research because of virus. And Dr. Padma Shri Ganga Khetkarji's presentation, I think, through the light that there are only three things that we need to take care of is increase the vaccination for all. It cannot be partial, otherwise it could lead to more mutations. The rate at which we are vaccinating will actually take us nearly 3 years to even reach to 75% of the population. If we are not going to adhere to COVID behaviors and 90% of us are not going to, it's not going to take us anywhere. The third and most important is that trials on the second generation of vaccine will now require to be developed so that herd immunity be developed not only for few, but as a pan-corona vaccine. Finally, the virus is much ahead of us, and we need to, from ourselves as people, society, continue actually just to put the thread together to all the presentation is support the government, our community by practicing safe behaviors for ourselves and continually advocating for continuity of the non-COVID services which have actually been adversely affected because of more attention to COVID. And just like summarize, like schools are being closed, it's more than a year. All the school-based nutrition health services have been affected. There is an attention fatigue amongst policymakers to think about anything else. The donor community and the livelihoods and the business establishments that have been affected has reduced the research and the focus on non-COVID issues. But COVID has not only affected survival, but the COVID-induced nutrition crisis is real. It has also thrown light on other important elements which get missed: overweight, obesity, mental health issues, moving towards telemedicine and how it can be done better. So it's giving us both solutions and a huge challenge. But the fact is that when these are the cards which are in front of us, we have to play our game well. And our country has moved speedily ahead, not only for ourselves, but for other countries. And your presentations show that there is hope. So with this, I conclude the important discussion points and hand the floor back to Dr. Sachdev.
Thank you so much, Dr. Vani. Now, I had requested earlier if the participants have any questions to any specific speaker, they could write it down in the chat and we could take them up. But just to set the ball rolling, Dr. Ganga Khetkar, it was a little scary thing, but one from the earlier experience, which one would say is that with time, the virus would probably be becoming a little less virulent. And if we talk of realistic or realism, I think there is no option except partial immunization. One can be, of course, theoretical and try to say that everyone should be immunized at that. But I personally, maybe you might call me a pessimist, don't see that happening in the near future or over the years, considering the wide inequities in vaccine production amongst the various countries. Now, one of my question to you is that do you think that the current uprise which is coming, which is sort of attaining a mini epidemic proportion like that, and it seems to be going up despite whatever happens, maybe because of COVID, inappropriate behavior. Do you think that the mutated strains have a role to play in this? From
No, sir.
whatever evidence is available?
No. I wouldn't say that whatever is happening is because of mutant strains. This is our way of blaming, shifting the blame from oneself to others. No, we must recognize that even today, even if this is a second wave that is uprising, we need to remember that if we go for a rapid vaccination drive, and if all try to curtail try to ensure that COVID appropriate behavior is followed, whether there is variant, whether there is no variant. The mask, safe distance is going to save us, and vaccines will save us from death. No, but we need to all get together to move ahead. To me, the reason why we need to think more is because of the scares that could come from the variants. But all of us must also know that everything is preventable if we continue to follow the COVID appropriate behavior.
Thank you. So, could you then sort of, just to carry the discussion forward, since there are no comments or questions in the chat, could you then explain that in places which had a high zero conversions earlier on? Yeah. Are there questions, madam?
Yes, Vinod Mishra wanted to ask question. He has raised the hand.
No, I said if they could type in chat, or will
Yeah,
they?
we can make them panelists. There is no problem in our program.
Okay, please go ahead.
Avinash, make him panelist.
Yeah, I just got made panelist. Thank you so much. Thank you also for this excellent panel. I really enjoyed. Very informative. I have one simple question for Mr. Ganga Ketkarji. My question, thank you first of all for providing us such a realistic overview. It's sobering, but I think it's it's much more realistic in the sense, a lot of people don't realize that the pandemic is here with us, and it's going to stay here with us for quite some time to come. So it's sobering, but it's realistic. And one thing that you indicated that one of the problems is that the problem cannot be, or the pandemic cannot be dealt with individually by countries. You can have very high levels of vaccination in one country, but if other countries are left partially vaccinated or not getting enough vaccines, you may have mutations, and the pandemic may just keep coming back to us. There are examples where countries are trying to collaborate on making the vaccines, or on producing the vaccines, or on distributing vaccines to other countries. So there are these international efforts that we all are aware of. But my question to you, sir, is that do you think that enough is being done internationally to collaborate in dealing with this pandemic? Seeing that there's going to be a problem if we don't do enough to deal with this problem as like one global problem, and what specifically you think more can be done that agencies like WHO or many other international intergovernmental agencies can pitch in to somehow deal with it as not individual country problem, but as a global.
Yeah, I think now I will try to answer it as I feel. One of the shortcuts that is being adopted is putting travel restrictions, but they will work only for a limited period of time. Whether you talk of RT-PCR negative reports to go to any other country, or whether you have received a vaccine not knowing if there could be a new variant which could evade that. So basically, no, those approaches may not work. I think what is most important for us to understand is take the entire community together. It is an issue of community mobilization. Provide vaccines to the prioritized group who have higher risk of mortality, but ensure that others don't land up into complacency just because they are not seeing infections, and don't use the COVID appropriate behaviors appropriately. If we bring these two together, only then we will have a sustainable incidence which would be low, and then we can aim at doing lot of contact tracing, testing of those who may be exposed to our mind, and isolate them so that it doesn't subsequently spread. So to my mind, there has to be a multi-pronged strategy. I think, when we look at entire population that is there in the world, we may not be able to do it across for every age group, but at least those older age groups, if we can prioritize together, that would make a lot of sense, because otherwise this is going to be a running battle. No, the virus will be a moving target. The virus is smart enough. It has changed within 1 year so much that whatever the first efforts of vaccine were there, it has been able to reduce the efficacy of those vaccines even for development of severe disease, if not, which is the first thing that we have achieved. Is there a hope? Yes, if we all come together. If you look at India, what our Prime Minister has done, he has started sending these vaccines to other countries also. Because these emerging infections teach one lesson, that geographies cannot stop, geographical boundaries cannot stop any infection from traveling. And unless everybody is safe around you, you can never become safe. And I think we need to walk that talk. We need to provide the vaccine. India is a large production house. And if you actually read the latest developments, even Quad, the major nations that have come together, they are talking of producing huge dosages of vaccine in Hyderabad through funding that comes from the rich nations as such. So there are efforts, but we need to intensify those efforts and rapidly roll out vaccines. That's most important for us.
Thank you,
Yeah.
Dr. Chandrasekhar. There is another question by Dr. Manas Ranjan Pradhan. Can the current spike in COVID-19 India is an indication of the beginning of a second wave, or will it be restricted to specific states or areas? You are being asked to do some astrology.
Sir, what I would just say, that it would not be prudent to believe that second wave is not there. Those states which are not showing infections, perhaps, if they start thinking they remain complacent, it would not be very fair thing to happen, because then you foster vulnerabilities by letting people believe that this is not there, so don't go for COVID appropriate behavior, or vaccination is not an important tool that is available to us. I would rather think that it would be good to look at worst case scenarios and try to address that issue to prevent the same. No, one can prevent it. We may have to keep on telling our population. We need to remember that there was a decline that we witnessed for almost 2 or 3 months' time. But within those 3 months, people started believing that this particular virus has almost gone and there is new vaccine that is on horizon. People don't understand the difference in this vaccine, that this vaccine does not reduce transmission or risk of acquisition of COVID, but it just reduces severity of death, severity and death from COVID infection. So we need to be articulate in our messages to ensure that we will be able to stop this second wave wherever it is as of now. And to me, that is completely preventable if we all act together.
Yeah, just
Yeah.
I had one
Yes,
question.
please.
For example, polio vaccination has taken decades to complete it. if you go for vaccination, whatever vaccination we are having for people who are aged and all those things, how many years it will take, whatever speed we are doing it, but that will take several years to cover whole world. What is your
Madam,
opinion?
yeah, madam, what I would say is, if you looked at the calculations that were done at the beginning of this week, when our numbers of people getting vaccinated every day was lesser than what it is today, it was estimated that we would require 4.3 years. And now that we have jumped to 30 lakh, it has suddenly come down to 3 years. Do we not have additional capacity to do it? We definitely have it. But we have to, as I say, we have to come together, ensure that we are able to offer these vaccines very quickly to our own population by expanding the scope of services related to vaccination across using good public-private partnership.
Thank you.
Thank you, Dr. Gangakhet. It seems this virus is not very susceptible to heat or other things. Our earlier wave was, or epidemic ascent was in summer, and the same seems to be happening there. Is it a different susceptibility to these in the temperate versus our climates? And second, do you have any comments about the lower case fatality in the South Asian context?
Sir, there could be two things. Some people tend to allege to us that our figures are not reliable, but at the same time, we must also remember that we have perhaps by far among all, we have a good public health system, health services delivery system. We used those 5 months of lockdown, where we delayed the onset of this curve to raise our capacity. And the advantage that we had was when the entire world was struggling to understand how to manage these patients, when the newer guidelines were still evolving and they were doing only experiments as to what they understood, for us it became easy, because by the time it struck us, we knew that you can use steroid well, you can enhance your supportive care to an extent that the risk of death can be minimized to a large extent. You need to provide high flow nasal oxygen and not put them directly on ventilator. Perhaps that reduces mortality. So we adopted both the patterns. Now world might say that we are missing the deaths, but the reality is most often when deaths have to occur, the hospital beds must be full. If you actually look at our decline, at that time of decline, you found that even in last 2-3 months, bed availability was never an issue. No, it's only recently when the upsurge is coming in those different areas, you are finding that beds are becoming difficult to get. They have to expand the scope. To me, we have done our best as of now. But what we require is a strong community mobilization. If we can do that, that would be great at this time point. Second issue with respect to temperature as a thing, as we are going on learning now, one of the things which we are learning is the surface transmission, to which we used to give lot of importance, is perhaps not as important as it appeared at that time, and therefore the role of temperature is getting minimized. Now, when I say minimized, what is it that is driving the whole thing? It is just that our population density is so high, our mobility is so high, that our exposures can occur rapidly, and the virus is able to find another body quickly enough to survive, because it has a finite period in which the virus can live in the body. So all these factors are impacting us. But though it appeared as scary for all of you, I'm sorry about that. But I must say that my optimism lies in only one thing. Can we educate our population and tell them that you will have to live with this COVID appropriate behavior, irrespective of the fact that whether you take the vaccine, you don't take the vaccine, because a vaccine may not work against a variant, but at least the mask, whether it is a variant, whether it is a new strain, the mask is going to protect you. The other safe distance, in fact, the good news is now it appears that 3 feet distance is more than sufficient instead of 6 feet that we used to talk about. So it is essentially giving us some kind of hope. And at the same time, just the hygienic part that you have to wash your hands as often and not touch your mouth and different areas that way is perhaps we need to popularize the whole thing, and then we will be able to make the difference.
Well, I don't certainly think that your thoughts were totally theoretical. They have sense in that, but the practical reality also has to be thought about. I think fear is the most important. Fear of death or disability is the most important motivator for people to adopt the COVID appropriate behavior. Once it gets less, I mean, people are sick and tired of sort of remaining at a distance, not going out for all that. And it's but natural. A fatigue 1 year is a pretty long time. And if I read you correctly, you are saying that it's for another year at least, if not more of the time that one has to do this. So do you think then that the vaccine with you presenting data, although which is not very robust, showing that the vaccine efficacy is reducing, does it make sense to work on the variants now, or do you think that this vaccine only which is currently available should be mass transported to all the countries wherein it may or may not be that much efficacious?
Sir, one thing which I feel, now I must put it that way, the virus survives for less longer time. It's only 15 days survival in the body. Now it tries to hunt for bodies where it can enter. Now, if I try to even partially protect individuals with whatever I know, I'm going to reduce number of bodies. Now, that probability that it will be able to enter in that body significantly. And if that starts happening, perhaps there is a hope to believe that not many people would require any such major intervention, because as I keep on saying, it is the mask. Mask can stop whether you have variant, whether you have any other wild type virus that is there. So essentially it would mean we have to follow the science for a short period of time rigorously. If we do that, we will be able to make a huge difference to my mind. Now, with respect to what vaccines are being planned, people are now thinking that maybe if there is a variant, which is not currently, the variants continue to be partially challenging the vaccines. But if there is a new variant, the way influenza tends to have, now if there is a new variant, we may have to develop one dose of a vaccine which could be administered maybe as a third dose, maybe as a second dose, as the time tends to come up at a later time. These would be second generation vaccines. And if that is one dose which can give us pan-corona protection, then in those cases, this virus can go, very quickly go. It all depends on how quickly we are able to reduce the number of infections in any setting by every measure that is available to us. Every body that the virus will get, it becomes a laboratory to produce variants. Now that should not be allowed.
Yeah. So the message is that the mask is the most effective vaccine, and the precise tailoring to specific strains is some distance away, but some protection is offered, which should be taken by as many people as possible by whatever vaccine is available to that person or country at that time, by whatever the methods it has been suggested. So there's the last question, I think, from the offices, can we have a cafeteria approach on vaccination?
Cafeteria approach is only possible if the viral platform on which the vaccine has been developed remains the same. No, if I'm looking at AstraZeneca vaccine, which is based on adenovirus, no, I should be able to pick up one from adenovirus group, that's Sputnik V vaccine. Cafeteria approach, if you are planning to suggest that whether multiple vaccine options should be available, they will be available. No, in a short period of time, to my mind, you will have multiple vaccines available. And there is a room to think that all vaccines would have more or less similar effectiveness rather than worrying about choosing one particular vaccine over other. No, that's the reason why it is becoming important that we don't need to bother about a different vaccine, but whatever is offered to you, it needs to be taken immediately as quickly as possible to ensure that, as I keep on saying, the number of bodies in which the virus can survive for a long time is reduced to the largest extent.
So thank you so much, Dr. Ganga Ketkar. Before I hand over to the organizers, my apologies to the other three speakers. They should not think that they have been ignored, but it's actually this issue which is effective everyone. So the questions have come to them, and whatever you have said is important, the other three speakers, and we do recognize all of that. So please accept my apologies. Professor Syed Anusa, I hand over the stage to you, thanking you for making me participate in this important plenary session.
Thank you, Professor Sachdeva, for making this discussion very lively as well as time management. Thank you once again. And thank you for coming to our seminar and participating in. And Dr. Vani Sethi for giving a brief discussion about all the papers presented in this session. So thank you, Vani, for participating in this thing. First of all, I like to thank all my panel members because with short period of notice, they have agreed to participate. And I like to thank Dr. Nilima for giving us positive as well as negative side of COVID, how the public health system had overcome so many issues as well as open up new things for the people. And the second is Dr. Sangmitra. She has also pointed out what are the things going on in the under the scenario of COVID, how people are managing their life, how they are coping up, and what are the difficulties people are facing. So that was a very good research work about community level work, and that has given us the good insight for our researchers, for our research scholars. And our Ramana is my student also. I feel proud to see him here presenting paper. And he has given a scenario about how different disease persons will have to cope up and what we can do and how it can be done. So thank you, Ramana, for participating as well as giving your studies research output. Thank you, everybody. All the participants as well as all panel members, all my organizers, thank you very much. ICT unit, thank you very much for this work because we are keeping you till 7 o'clock in the office. Thank you, everybody. Now we will close this session. Thank you, Professor Sachdeva.